In pregnant diabetics, where the pumps are often used in type 1 pregnant diabetic and very, very effectively, there your targets are slightly stricter because, as we know, the ambient blood glucose in pregnancy as such is low, and therefore you would like to simulate the natural blood glucose profile in a pregnant woman, and therefore you'll find that the targets are stricter and A1C target is less than 6 in this situation. So the pump in addition to providing the insulin efficiently and reducing the variability of response, the patient has tremendous flexibility when the patient uses pump. As a matter of fact, most patients feel liberated when they are put on pump therapy, and there is a chance that once they use it very effectively, even their follow-up require maybe only a couple of times a year if the patient himself or herself is monitoring very closely and informing you of A1C results. Pump may be programmed to adapt to daily activity and day-to-day varying activity, and even the dietary restriction can be relaxed to a great extent. And therefore, you see, patient satisfaction and motivation to use pump is very good. The safety reliability is quite a bit. As a matter of fact, you can see that experience now is not even 15. In fact, it's now 20-25 years that advanced pumps are being used, you see, and there are a lot of messages, alarms, all built up in the pump system. At this point, I would ask my associate from Roche to show you an example of a pump, what it looks like, and the basic features of the pump. So Mr. Vick.
We have a AccuCheck combo. AccuCheck combo having two devices which is paired via Bluetooth. That's why we call AccuCheck combo. This is the insulin pump. We have a model. In this there are 4 buttons is there. One is menu, one is check button, and 2 is back side of the pump is up and down. Cartridge is filled here inside the pump. Normal cartridge are look like a syringe. We have just sucked the insulin from the cartridge and just fill it. Then we remove this syringe and put inside the pump. Like this. This pump can fully operate with the help of this remote control. This is also a blood glucose monitor machine, and it also a bolus advisor. Sometimes when patient check their blood sugar level while pricking method, this pump automatically tells the exact amount of insulin has to be taken to get the normal range. This is also electronic diary which captured 4,500 events, our last 3 months data. Entire data, either you switch off the pump, switch on the pump, remove the battery, any kind of data is captured and stored. So doctor came to know what times when patient goes hypo or hyper, what is the condition of the pump. This is also inside we have the colorful flagging which maintain our HbA1c, like there are some graph is there. So patient came to know what is their HbA1c, because if here the patient can maintain the pie chart 65% in green zone, their HbA1c is compared 7 to 6. As per protocol, this cannula has to be changed after 72 hours, and this infusion sets and the cartridge has to be changed after 7 to 8 days when the insulin get over. This is all about the insulin pump features, normal features.
The type of insulins that we use in pump are always the regular type, although you can use human regular in the pump, but it is preferable to use any of the rapid acting analogs like Lispro or Aspart insulin in the pump. It has been shown that both of them have stability over 3 or 4 days in the pump reservoir, but a slightly better stability has been shown with Aspart on the last day, that is day 3, before the cannula is changed. Now, the indications of pump therapy is where any type 1 or type 2 has not been possible to control diabetes in spite of using multiple dose insulin therapy and combining with a sensitizing agent. So in that case, you can consider pump therapy. Whenever very flexible lifestyle is sought by someone, again pump therapy is the right one, see, and patients with, of course, difficult to control. Any patient having recurrent diabetic ketoacidosis type 1 would do better with pump therapy, although there again the pump malfunction can produce DKA. However, there are sufficient safeguards in modern pumps to detect any malfunction. And of course, pregnancy, where you want very good metabolic control, and in type 1 it is very difficult to achieve that with multiple dose therapy, then again pump therapy is worthwhile even in type 1 and very rarely also in type 2 pregnant women. What are kind of complications occur with pump therapy? The commonest complication is local infection at the site where the cannula has been inserted. We have found that if there is a thorough sterilization of the skin by wiping it twice with alcohol swab, with intervening waiting for about 5 minutes in between, then the possibility of infection is almost reduced to 0. Diabetic ketoacidosis is possible if the pump malfunctions and there is not an alarm system for a particular malfunction. Most of the malfunctions there is alarm systems, and it is still being improved every year, and therefore this has become a great rarity at the present time. Hypoglycemia is always possible with insulin therapy in general, and pump therapy also can do that, but it has been shown by a large number of pump users and a lot of publications that hypoglycemia actually minimized, and as a matter of fact, a patient type 1 who is extremely sensitive to insulin therapy going to recurrent hypoglycemia also is an indication to institute pump therapy for that particular patient. So hypoglycemia actually can be very effectively minimized by using pump therapy. As a matter of fact, it has also been shown that hypoglycemia awareness also can be improved, because with pump therapy, if there is a hypoglycemia unawareness, one can easily leave the blood glucose is slightly higher for about 2 weeks time, where the awareness is again restored, and therefore it's one more tool for you to tackle the hypoglycemia unawareness. The cost considerations are important when you use the pump. There is a cost of the pump initial, and then some education. We feel that at least 10 sessions of hour each are required in order to truly prepare the patient to use the pump very efficiently, and there is a cost of that, and of course the consumable cost is there. So altogether consumable cost at the present time in India would be about 4,000 to 5,000 rupees. The pump costs are anywhere minimum about 90,000 to about 3 lakhs. So initial cost, little bit of education cost, which is one time only, and the consumable cost. However, the cost of syringes and needles is saved. The insulin cost is same in pump as with syringe and needles, so that is common to both, or as a matter of fact advantageous in pump therapy. The A1C lowering is pretty good by pump. The quality of life is better. Flexibility is there, as we told. Controlling in type 1 the DOM phenomenon, which is very difficult with subcutaneously injected insulin, is possible with pump therapy. Hypoglycemia is less, I told you. Type 1, it is far more important to use pump than in type 2, but in type 2 short term also the pump therapy will give you much better results. So we had considered this cost as I described for you. Next slide. Now we'll be passing on to insulin pump algorithms. First I'll give you some simple algorithms on pump therapy, followed of course by some advanced algorithms for you, and some of this you will again find described in the text material available at our website in great detail. And there of course we will also describe the features of commonly available pumps in the country, which of course belong to mainly two companies, the Roche and Medtronic. Now the targets we already discussed. Next slide. Okay. It's not moving. Yeah. Now we will be discussing the insulin pump algorithms. We had already looked at the target values which you desire to achieve on pump therapy. Now how do you achieve that, and how do you plan your basal and bolus doses on the pump therapy? Now what you do really is you look at the patient's total insulin dose. For example, let us say somebody took 100 units, then you reduce it by 25%, so the patient should really get 75 units on pump, and you divide that into two parts. Half of the requirement for basal purposes, half of the requirement for meal related or what we call bolus purposes. So about 37.5 units here and 37.5 units here in this instance.